Thank you very much, Dr. Hu. I'd like to invite our next speaker, Professor Wang Jinsong from Guangzhou, China. And she's going to talk about endovascular management on chronic post-dissection for abdominal aneurysm. Jinsong.
Thank you, Professor Zhang, and thank you, President Professor Yu's invitation to Vietnam. And so I appreciate everyone's kindness to me to make this trip very successful. And I would like to share our experience on the endovascular treatment for chronic post-dissection, TAA. And we know for the post-dissection TAA and endovascular management, at the first beginning of the dissection, nowadays we use the TVAR to cover the first tier interval for the acute dissection. But gradually, the distal part of the thoracic aorta will become aneurysm eventually. And there's some devices like for embolizing false lumen, like FLG, kinetic blocker, to reduce the enlarge of the distal aorta. But nowadays, penetration and branch EVAR and have a good early and midterm efficiency and good aortic remodeling with lower morbidity and mortality. Nowadays, it looks a promising alternative strategy for open surgery for the post-dissected TAA. And but it is very challenging for the endovascular treatment for this chronic post-dissection TAA because it's limited access due to the ascending aortic replacement and the supral arch branches changed its original anatomy position, and the previous thoracic stent graft deployment to seal the primary intimal tier, and sometimes it's have the occluded left subclavian artery, and some patients will comorbid with occluded iliac artery and the narrow true lumen, and the visceral arteries originated from the true or false lumen, and plus the lungs deployment of the stent graft will cause the spinal cord ischemia. And nowadays we have off-the-shelf commercial penetration or branch products, but because of the complicated situation of these patients, so physician modifies the penetration or branch stent graft is popular and in China. And for the basic techniques, we all know from the textbook, there's the tricks in technical tricks in doing this. And I want to share our cases. This is case one. This is a male, 73 years old. And in 2024, he presented to the cardiac surgeon with the arch aneurysm more than 4 centimeters. And he also had abdominal dissection aneurysm more than 5 centimeters. And the cardiac surgeons performed the bypass and put a stent graft in the arch. However, they didn't embolize the left subclavian vein, so there's type 2 endoleak. And but after the patient discharged from the hospital 2 weeks later, and the patient went back to the ER again because the abdominal pain, and we can see the patient have the contained rupture of the thoracic aneurysm. So, but the patient had very difficult challenges due to there's no left brachial access, And the right brachial artery access is limited by the bare stent of the previous thoracic stent graft. So we decided to candidate the, we use the fenestrating method, and we candidate the SMA and the left renal artery and in sequence, and because of the limited access. And for the left renal artery, because the very narrow true lumen, so it's a misalignment of the fenestration of the left renal artery and the ostium of the left renal artery. And so we had to do the in situ fenestration for the left renal artery. And this is the final angiogram for this patient. And in 2 weeks later, and we embolized the left subclavian artery, and the follow-up, there's no endoleak, and the patient recovered well. This is a 45 years old male, and he had a type B duct dissection 10 years ago, and a stent graft was employed in the descending aortic aorta. But it occluded it covered the left subclavian artery. And his blood pressure was not well controlled. So he had all sudden abdominal and back pain. And the CTA shows the contained rupture of the iliac aneurysm. The patient just very lucky, and he had this rupture in Xinjiang, and he even flew back to Guangzhou for further operation. And the patient have difficulties because of the limited access of the upper brachial access, and the spinal cord ischemia for the endo, and he had a very narrow true lumen. And so we put the patients in 2 stages. First stage, we treat the sign of the previous stent graft and reconstruct the left LSA, and to avoid the spinal cord ischemia. And this. So this is we do the in situ fenestration to reconstruct the subclavian vein. And the 2 weeks later, and we perform the second stage. And first, we embolize the pseudoaneurysm, the left iliac artery through the right femoral artery. And then we use the right brachial artery access for fenestration the SMA, left renal artery, and one by one, because of limited access. And it's so difficult to access the right renal artery from the above access. And after we remove the stent graft, and we candidate the right renal artery through the right femoral artery, and that's lucky. So the patient was recovered well. And this case is a 64-year-old female, and she had Marfan syndrome. She had ascending aortic deployments 10 years ago before her before her admission to the hospital, and she had enlarged post-dissection TAA to 7 centimeters, and the patient had no upper brachial access due to the previous operation, and only 2 femoral arteries for access, and SMA and the right renal artery originated in the true lumen, and the left renal artery and the celiac originated in the false lumen. So we use the stent graft, and we performed the 2 pre-fenestration in for SMA and the right renal artery, and we prepare 2 in situ fenestration and branch for the left renal artery and the celiac artery. And we performed the IBD for the right internal iliac artery to avoid the spinal cord ischemia. So this is the final result of the fenestration and plus branch method for these patients. And this is a 63-year-old male, and he had renal failure, and he had a previous type B dissection, had a stent graft employment, and the orange of the left subclavian artery was covered, and the distal dissection, the TAA. And for this patient, and the lucky issue for this patient, his left vertebral artery originated from the aorta. So we first angiogram to be sure his vertebral left vertebral artery was patent, and then we embolized the left renal artery due to no function. And we use the left femoral artery for penetrated stent graft, and we use the right femoral artery for cannulation of visceral arteries for the reconstruction of the visceral arteries. So that's the final angiogram for this patient. And this patient is 68 years old male, and he had previous type B dissection, and his left renal artery originated from the fourth lumen. And we had the SMA, right renal artery, and the celiac penetration. And because the left renal artery, there's the thrombosis between the true lumen and the fourth lumen. So we use the branch for the left renal artery reconstruction. And this is a male, 59 years old, and he had the replacement of ascending aortic artery due to the type A dissection in 2015. And we can see with the years, his distal part of the thoracic abdomen enlarged from like 4 centimeters to 11 centimeters. And he had no upper brachial access due to the previous operation, and he had a narrow true lumen, and he has like the SMA originated from the fourth lumen. And in this patient, we also use the fenestrations plus branch for SMA to reconstructed the visceral artery. So when you do the diameter strain, it's very challenging sometimes due to the narrow true lumen. So actually, this left renal almost misaligned with the oscillating of the left renal artery. So it takes a long time to we put the balloon here, and then find the space to cannulate the left renal artery. And this is the branch of the SMA. And this is the final result of the angio of the CTA, and there's no endoleak for this patient. This is our 54 male patients, and he also have the replacements of the ascending aortic artery due to the type A dissection in 2016. And he all of a sudden complained of sudden abdominal pain, and he was admitted to the hospital, but 8 hours later, and he had content rupture because the blood pressure just dropped down, and his hemoglobin just dropped too. And he had heart function heart dysfunction with the left ventricle ejection fraction is only like 40%. So in this case, we also we embolize his celiac artery because it's very narrow, and we do the penetration of the rest visceral arteries, but it's so difficult to cannulate the right renal artery, so we perform the in situ penetration for the left renal artery, and that's the final result of this patient. And this is a 52 years old male. He complained he had a previous type B dissection, And then he had all sudden abdominal pain. He was admitted to the hospital, and we can see he had a very, very narrow true lumen enlarged fourth lumen, and his visceral arteries all originated to form the fourth lumen. And so we found the situation, the visceral arteries all form the fourth lumen, and this is the final result of the angiogram. So in literatures, we look back like this is multiple center data from 4 Italian centers, and they reported TAA, and we can see like post-dissection TAA it's not that common, it's only 11% of this patient. And with the endo, and this shows their result shows the safe and good result for the midterm follow-up. And in German, and they treated this literatures reported like 50 this multiple center, and then they reported 55 patients post dissection TAA, and with various of endovascular method, and they had the 30-day mortality was 7%, and the May rate was 20%, and the spinal cord injury was 13% and 2%. So their data shows it's pretty safe for the endovascular for this patient. And recently, in the guideline of the European Society for Vascular Surgery, endovascular repair was with fan-treated and branched techniques should be considered the first-line therapy in patients with CART type B aortic dissection and aneurysm formation involving the TAA. And in summaries, for these patients, meticulous preoperative evaluation and protocol was necessary. And at least 2 accesses, one for the fan-treated stent graft deployment, and one for and canalize all the visceral arteries. And there's no necessary for this patient to put all the hardware in the wire in the visceral arteries, and we can re-establish these visceral arteries in orders: the SMA first, and the one renal artery, and the other renal artery, and the celiac artery. And so the diameter stream depends on the true lumen size, but it's very challenging to string them on the back. And in the emergency, in situ filtration for the visceral arteries originated in the fourth lumen or misalignment is very necessary. And so this is the experience of our center for these patients. Thank you very much.
Yes, thank you very much, Professor.